Transforminal lumbar interbody fusion, or what is popularly known as TLIF, is one of the most common spinal fusion procedures performed in private practice. Transforminal lumbar interbody fusion essentially means that one is approaching the disc space for the fusion through a posterolateral route by excising the medial facet of the vertebra and excising the superior part of the outer facet in order to approach the disc space. This allows a posterolateral access to the disc space and reduces the amount of nerve root and dural sac retraction, and therefore reduces the risk of injury to these structures. Complications during this procedure can occur at one of many steps. Let me take you through them. The first step in the surgery is the positioning of the patient, and as we all know, the key steps during positioning are to avoid any compression of the abdomen in order to prevent back pressure changes within the spinal canal and increasing the venous engorgement. So this can be done by adequate positioning of bolsters and, if necessary, putting in a Foley's catheter. I do it only when I do multi-level fusions. The spine, the cervical spine, should be kept in a little bit of flexion. Often elderly patients undergoing TLIF have coexisting cervical stenosis, and they may get up with worsening of a neurologic deficit if the head is kept in an extended position. Of course, the usual precautions of preventing pressure on the eyeball, pressures on the various pressure points, and over-abducting the arm need to be taken care of. The exposure needs to be precise and perfect. One must take and mark the incision before taking the incision, and again confirm the position once the exposure has been completed. This way we avoid wrong level surgery, which is not uncommon during minimally invasive spine surgery, where one does not get any feedback from surrounding landmarks. The initial exposure should be very careful to avoid bleeding, and therefore subperiosteal dissection is done up. Be very careful not to damage the facet capsule, because you don't want to promote accelerated degeneration or instability at a level which you are not going to fuse. For a posterolateral fusion, one tends to expose right up to the tip of the transverse processes. But for a TLIF, exposure just lateral to the facet joint so that one can insert the screws should be enough. The next step, of course, is bilateral pedicle screw insertion. This should be done under C-arm control in order to, both in AP and lateral views, in order to prevent misplacement of the screw. Malposition of the screw is found in about 2 to 2.5% of patients and may result in nerve root or dural injury. Malposition can result in pedicle fractures and loss of fixation within the vertebra, which then becomes a huge problem. To avoid malpositioning, adequate lateral exposure, control bleeding, identify landmarks properly, and use the C-arm. Once the screws are inserted, assemble the contoured rod onto the opposite side and then gently distract between the rod in order to restore foraminal height and increase the disc height. The next step is decompression. You can choose to decompress in whichever way. This is the time when dural tears are common. You can also get nerve root injury if you are not very common during the decompression procedure, but the nerve root injuries are rare. Epidural bleeding may be encountered. You may not do an adequate central canal or lateral this as decompression if you are not careful. Decompression can be done in the form of laminectomy, a hemilaminectomy, an interlaminar fenestration, or an under the roof or decompression of the opposite side. Having decompressed, one now needs to knock off the facet joint in order to be able to access the disc space for the TLIF procedure. Which side should you resect the facet joint from? The side on which there is a significant neurologic deficit, the side with the worst radiculopathy, the worst compression, on which side there is a disc prolapse or a facet cyst, or in the concavity of a scoliosis. The resection of the facet involves complete resection of the medial facet of at that level, and the lateral facet the upper half is removed, amputated at the level of the superior border of the pedicle so that there is enough space to go in for the disc space. Having created exposure for the approach to the disc space, it is now time to deal with the nerve roots and the epidural vessels. The epidural veins, which just lie anterolateral to the dural sac and within the facet joints, are gently retracted with a penfold 10-4 retractor. If necessary, hypoalveolar coagulation can be used. Cottonoids are used. I like to put one cottonoid along the traversing root to push it medially. I push one cottonoid up into the axilla to push the exiting root upwards, and I push a third patty laterally and upwards to retract the lateral part or the outer part of the exiting nerve root upwards. This gives me fantastic view of the disc space. Sometimes during this time, bleeding may be encountered and you can use a bipolar cautery to stop this. Now time for a discectomy. Make sure that when you are doing a discectomy, you do a thorough discectomy, but do not remove excessive end plates when using shavers and curettes within the disc space. The next step is to prepare the end plates, bone grafting and cage insertion. During end plate preparation, one should be careful to use your shavers, the curettes, and even the inserting the rasps and the templates parallel to the disc space. This is especially difficult in spondylolisthesis, where the angulation of the disc space may be more significant and the disc space may be significantly reduced and blocked by the lower border of the upper vertebra. If you are not careful with the adequate angulation, you may land up excising significant amount of the superior end plate, which then results in significant bleeding and then may result in cage subsidence and cage migration. Having done an adequate disc space preparation, one starts with bone grafting. If you do not have adequate bone graft, then you can do a small incision and get some graft from the posterior iliac crest, or what I like to do is put in a bone marrow aspiration needle and aspirate some bone marrow to mix with my autograft and put it into the disc space. A majority of the graft goes outside the cage, anterior to the cage, and the cage also is firmly packed with the graft. Having inserted the graft, it is time to insert the cage. The template should be such that when you insert the cage, the template, and then you try to pull it out, the entire spine gets pulled up. That means that you've got the right height of the disc, and that is the size of the cage that you should use. I typically use a 22 to 24 millimeter long cage. This cage is inserted into the anterior two-thirds of the vertebral body after the bone grafting. I prefer to use a bullet-shaped cage rather than a banana cage. The bullet-shaped cage is much more easy to position. It requires less space when entering the canal, so the retraction of the nerve root here is far lesser. Once the cage has been adequately positioned, the alternative to this bullet cage is the banana cage. The banana cage requires more room laterally for insertion of the cage, and it is difficult to position the cage adequately so that it is parallel to the anterior annulus, which is its ideal position. Which material should you use for the cage? There are two materials which are commonly used in India. One is the PEEK and the other is titanium. The advantage of titanium is not only is it bio-inert and therefore biocompatible, but it also has the advantage that it has a better osseointegration than the PEEK cages. The PEEK cages have a tendency to cause osteolysis around them, and therefore there is a risk of subsequent cage migration and cage subsidence. Be very careful when you are inserting the cage, because if the cage is slightly larger, you tend to retract a little bit more, the axilla gets stretched, and that is the time when you can get a dural tear. You may also get bleeding if your cage is not in the proper position and is mashed into the vertebral end plates. Be very careful to retract the patty during this process, because sometimes if the cage is large, it takes the patty with it, and then the patty gets jammed in the disc space and is difficult to remove. The final stage is rod assembly. During this, be very careful to protect your dural sac. I usually put a mop over that when I'm doing rod assembly of the ipsilateral side, so that the instrument doesn't slip and cause any dural or neural injury. Be very careful when compressing, because when you compress gently, there can be an osteoporotic bone, the pedicle screw can cut out and cause a nerve root injury. So what are the common complications? We'll talk about them. One of the most common problems following TLIF is leg pain, burning, dysesthesias, numbness, and even swelling on the side from which TLIF was performed. This is because we are working in the area of the dorsal root ganglion, which is extremely sensitive to pain. And when you retract the exiting nerve root too much, or you handle the dorsal root ganglion, these symptoms are not uncommon. How do you prevent this? You prevent it by doing adequate mobilization of the nerve root right from the lateral recess outwards into the extraforaminal region. Retract the nerve root with patties at 2 levels, as I have described, and distract between ipsilateral screws, either using lamina spreader between spinous processes, or Synthes offers this distractor, which is a lateral distractor, and it fixes into the screws and you can distract, and this works beautifully. Be very careful to retract the dural sac adequately. You must tell your assistant that with the dural retractor, he should retract the dural sac, and he is free to press downwards because the annulus is there and he is not going to cause injury, but he cannot retract it medially too much. Be careful to protect the nerve root with your patties. Do not oversize the cage, because if you oversize, there is difficulty in inserting the cage, and that results in an axillary neural tear. Cage malposition can be anterior if you have been too aggressive in inserting your cage, and we've had a situation where we've had to go anteriorly and get hold of this cage and bring it out. The more common problem, however, is that if the disc space is collapsed, if your end plate preparation is not proper, then or the cage is oversized, the cage will land up getting jammed within the vertebral body, and as you try to hammer more, it doesn't go in, it just results in profuse bleeding, and the cage gets jammed because it has cut through the end plates on either side. So use a distractor. That is what is going to, and make sure that you have got adequate angulation of all your instruments when inserting the cage. Cage subsidence is another problem that we see, and it is typically occurs in osteoporotic bone or in patients where we've used a very large cage, which is even bigger than the height of the adjacent disc, and when the end plate preparation has been too aggressive. At the beginning of my practice, I used to be fairly aggressive in my end plate preparation, but today I'm much more gentle and restricted in my end plate preparation. The last two complications we talk about are cage migration. Cage migration occurs in about 1% of patients. Cage migration is typically posterolaterally in the direction from which you have inserted the cage. And because there is nothing in that area, typically except for back pain, patient doesn't get much problems unless the cage comes out completely, and then it starts irritating the nerve roots. Non-union is another problem, and it can be avoided by optimum end plate preparation, inserting bone graft outside and within the cage. So to conclude, TLIF is an extremely safe procedure. Very good results, 80 to 90% patient satisfaction. However, a fair number of patients do complain of residual pain or new complaints such as persistent burning, paresthesia in the leg. One of the tricks I use is to use a gel foam soaked in Kenacort and putting it around the dorsal root ganglion of the exiting nerve root in order to reduce the inflammation in this area. So, and the final tip is adequate exposure, proper protection of neural structures, control of epidural bleeding, Optimum end plate preparation and proper sizing of the cage will allow you fantastic results after a TLIF procedure. Thank you.